with you, our community, our simulation education community is wonderful. So welcome. I'm Lou Clark. I'm the incoming director, executive director of M Simulation at the University of Minnesota. And today we welcome you to this Zoom presentation, Zooming with SPs in COVID-19 response. And we're going to be using Zoom to train SPs and implement formative OSCEs with health science students. That's the name of our presentation today. Next slide, please. We have nothing to disclose. I think it's actually incredibly important to say we have absolutely no stake in Zoom as a company. Like many of you, we are just using it to try to make these events happen. So none of us have a relationship with Zoom. Next slide. Today, you, the audience, it's so important you're here, and we're so happy you're here. As I've mentioned, and if some of you are just signing on, please sign into the chat so we can provide resources and follow up with you. If you could please include your name, your institution, your email address, we'll get back to you and disseminate. Please keep your video and audio muted during this presentation. It will be easier because we have many people now. It will be easier for you all to focus, and it'll keep the noise and the sound of distraction down. We ask you to please hold questions until the end and then type them into the chat function when the question slide appears to cut down on distractions. So once everybody signs in and shares that they're here, hopefully that chat function will, it'll just sit there until we get to the questions. Next slide, please. I wanted to share, this is our entire M Simulation team. For those of you who have smaller programs, I don't want you to get a lump in your throat and say, oh my gosh, how can we do this? We do not have this sizable team. I do want to share that it was important to put the whole team up here to acknowledge them, because Joe and Ann and I are representing the work of many, many people today on our team who've done a wonderful job coming together and mobilizing this effort in 2 weeks. It's important for you to know that at least 5 of the people up here are part-time, very part-time workers. But again, thank you to our team. Next slide. We also want to acknowledge that we have had tremendous partners in leadership and our communication team, on our faculty. One of our wonderful doctoral students in the nursing practice program has agreed for you all to see her video today. We have a simulation oversight committee that provides guidance for us, representing the health professions across Minnesota. And we want to thank them all. We could not be doing this and mobilizing this as quickly as possible without the support of so many people. And I think this speaks to the fact that each of you at your institutions, please reach out to your leaders, reach out to your constituents if you're not already, and get them involved. Let them help you with this effort. Next slide, please. So with that, I want to introduce what we're up to. So we are offering a session today about Zoom, but the session is designed to be the first in a series. And the series is geared towards sharing information with our community about how to utilize online platforms to train and implement and keep our events going. So it's in response to COVID-19, but the idea in the title of this series, Healthcare Simulation Online, COVID-19 Response in 2020 and Beyond. I think the beyond part is so important because we will get beyond this. And when we do, we know already, many of us, all of us probably know, that what's happening now and how we're being called on to adapt our learning to educate our healthcare providers and workforce is so critical in this time, but it's going to change how we do it in the future. And so we need to mobilize, we need to see that those opportunities are there, and they're going to be there when this time passes, and it will. Next slide, please. So with that, today we are here to give you a session all about Zoom. We know that that's what people need right now, and so we want to share this work. We do want to say Zoom is not the only platform on the market. There are many others listed there, and some of you may be working with that. But we hope and we think that the lessons we're going to share with you today will hopefully be applicable to some of those other platforms. It is also very important to say that our staff had very limited experience with Zoom until 2 weeks ago. 2 weeks ago, and you can see the picture on the slide, we were all looking at each other saying, how do we do this? And even, can we do this? And I think this is such a crucial time to say to you, you can, and don't be afraid to try it, because if you can try it, you will get there. This was just 2 weeks ago. And so with that, I'm going to ask for my help from my driver. We're going to give you a poll, and we're going to give you about 30 seconds to complete that poll. And the poll is looking at how comfortable do you feel using Zoom. So go ahead, folks, and let's hear what you think. And we'll give you just another 10 seconds or so. Got a great response going. Okay, let's close that poll. And we'll share our results. Okay, so I do want to share with you that right now we have 300 people on this call. And so you can see the results here. So interesting, right? We have about 40% either somewhat or not comfortable at all. We have 38% of you are mostly comfortable, but you signed in anyway to see what we're up to. And 19% are very comfortable. So this is great to know where our audience is. So thank you for that, Joe. And so, let's see here. So now, more to think about briefly before we get into the nitty-gritty. Our session covers adaptation and implementation of our face-to-face formative OSCEs to a fully online Zoom platform. And we're going to highlight a small-scale event we did for 15 graduate nursing students and start there and show how we scaled up to a much larger event with over 100 students in veterinary medicine. We're going to include aspects around using a narrative style to work through the physical exam findings, which we did. But we do want to be clear that this session does not include training physical exam maneuvers and psychomotor skills at home. So just to be clear about that. And again, we're recording this, materials forthcoming. And with that, I'm going to turn it over to my colleague, Anne. And we'll go to the next slide. Oh, I'm sorry, we've got one more. We've got session objectives. Here we go, session objectives. I think you've all seen these in the announcement, but here they are. We're going to cover logistics, training SPs, meaningful debriefing. Next slide.
All right, so we are going to start talking about our first project, and we're focusing a lot on that because we ran this just last week. It was smaller in scale, but we learned the most so far from this project because of where we started and how quickly we did that. This was an OSCE, it was a formative OSCE originally scheduled for last Friday to be on site for, as Lou mentioned, our 15 second-year nursing students in the graduate nursing program. And that design had been modeled on how we'd previously run the project last year. We were anticipating 3 hours on site using 4 SPs who would each portray the same case, an abdominal pain case for history and physical exam. We were giving 20 minutes for the encounter, 5 minutes of feedback with the SP, and of course an orientation and debriefing. That was all well and good until we got the announcement to move home with all of our SPs going to their locations and students as well, which gave us 1 week of lead time to convert this. So one of our initial strategies in response to that was to reach out to faculty and start to discuss what are some of the options. How can we continue to meet some of these learning objectives via Zoom? The communication aspect of this type of encounter seemed well suited to use the telehealth format, and where we focused a little more of our conversation was, what do we do about physical exam? How are we going to meet some of those learning objectives? And where we landed was embracing essentially a verbal findings approach, something very similar to a findings card that standardized patients might use on site, and asking students to narrate the physical exam. And we'll talk a little bit more about this process as the presentation continues. But the important piece from our perspective in designing this was that it still allowed students to practice decision-making skills. So thinking about which maneuvers they wanted to perform, interpreting the results from those maneuvers, and developing a differential and plan. The original schedule looked much like the adapted schedule, with the difference being that the original locations were moved into Zoom virtual locations within the meeting. And as you'll see, we have the pre-briefing taking place in a main meeting, which is essentially where we are now in a Zoom meeting, and then we had planned to use breakout rooms. This still allowed learners to each have an individual encounter with the SP and to maintain that same originally planned time frame. The other first response we had in managing this transition was to reach out to our SPs and understand what resources they had at home, what experience they brought from using conferencing tools previously, and what level of confidence they had. And I think it's interesting, I was pleasantly encouraged that 74.5% of the people responding had a device and what they thought was a reliable internet connection. That gave us a lot of hope for what we might be able to do in the scale we could do it. And many of them, 55%, had some experience using online, and a few more had significant experience. Only a quarter didn't have any experience with online video conferencing tools. And with all of these different variables, these are just a couple of the questions we surveyed. I thought it was telling that they still felt very confident. 62% thought they could be confident that they could be an SP via Zoom from their home, which was really encouraging to know where we were starting from and what the interest was in continuing to support this work from our standardized patient population. I'm going to turn it to Joe to talk about case materials.
So yes, thanks, Anne. As she mentioned before, after having conversations with our clients and really thinking about the recalibration of this project, one of the next steps was really how do we adapt the case materials? You can see on the right-hand side, I've put the example of the actual verbal cueing sheet for the standardized patients for this very first project. In collaboration with the faculty on this document was created, gave instructions for the standardized patients on when to give these findings, and also just generally thinking about and anticipating what sort of things the learner would be expected to do or would be thinking about for this particular case. So I'll let everyone just see those for a quick second. Another thing that came to mind as we were talking with faculty and our team is that what do we do about COVID-19? When you're thinking about asking the patient about their stress level, that's probably heightened with everything that's going on right now. Thinking about the work-life balance, the social support system, a lot of those things really add in, are gonna have different considerations in thinking about the current climate that we live in. So a choice was made to either appreciate and acknowledge what's happening right now. Another choice could have been to kind of ask the learners to suspend disbelief and really engage with the case the way that it was written. But we did factor in and account for those considerations in the case details to think about some of the things that might impact the portrayal of the character. We also thought about telehealth versus the original context. For this particular simulation, it really felt like it was adaptable to that telehealth format. We were able to have that focused history, as well as with this physical exam being narrated, allow the learner to critically think about the clinical decision making that they would be making or asking in the room with the patient. With the next word you can see here, this was something that we learned from the experience. It's a very challenging word to say, and our standardized patients definitely had some issues with that. So one of the things we learned in adapting case materials after the fact was that you need to make sure that the terminology is in lay terms as much as possible, so that the learners and the patients have an easy and efficient experience. And one of the other things that became really critical is also making sure that we sent links to Zoom tutorial videos with the case materials. That really helped us with the onboarding and making sure patients at least had some resources to start navigating the technology and knowing that we need to be there to partner with them and help them in the training process. So, and that's a great segue into my next slide. So for SP training and coaching, a lot of what we focused on here was about the same of what we'd done before. We followed our typical agenda and really thought about the considerations that would be impactful for the standardized patients. We did an introduction to Zoom. Really, a lot of that was troubleshooting, facilitating discussion, and as you can see, navigating the new normal. This ended up taking about 40 to 45 minutes of that first session to really help individuals figure out exactly what they needed to know about the platform. One of the challenges with Zoom that we figured out so far is that depending on the device you use or the platform, the Zoom features are different. And so I quickly realized that you had to resist the urge to say at the bottom of your screen, at the top of your screen, go to the left, go to the right, because that's different across platforms. And so think about that as you're thinking about the training process, because the standardized patients will really need your guidance to help you or to help navigate the technology. One of the things that we decided to do was we also decided to record all of the SP training sessions because we had that functionality with Zoom. Our standard protocol is not to record all of our sessions, so that was something that you'll need to, or we needed to consent our standardized patients at the very beginning and make everyone aware, as well as the staff and faculty that were joining those training sessions. As a positive, we now have recorded or have a record of all these training sessions moving forward, which is going to be really critical in helping with any one-off sessions and or any retraining. We asked the standardized patients to minimize distractions. I think some of you might have just heard my dog bark. So we asked them to try to make sure their pets were elsewhere and do the best that they could to really have a focused environment that would be conducive to learning and really partnering with us, as well as thinking about that for the event with the students and making sure that the student really has their full focus. We kept it simple and consistent. We tried to make sure that we were following our typical protocol and our format that we did if we were doing this in person. So that's one thing that we were thinking about. And then really we found that it was critical to use demonstration and role play via technology. The use of video is something that was accessible to us, but we really wanted to make sure that we demonstrated for the patients first, and then also had them do role play with the technology so that they got the flow and the cadence of speaking through technology and really not speaking over each other. Next slide.
So I'm going to talk about SP training observations. I was a fly on the wall in this training, enjoying it, seeing how it was going. But before I do that, we had a message come in over the wire, and so I'm going to reach out to my technical lead here, Joe. And so this is happening in real time. We're going to see if we can work on an adjustment. So we have heard from our Associate Vice President, Carolyn Porta, that we are capped at 300 participants, and is there any way to manage that, Joe? So I'm gonna throw that over to you.
Just saw that.
I'll go, yeah, and I'll keep going on these observations. So if you have colleagues who are trying to get in, this is us trying to troubleshoot Zoom in real time. I thought that'd be kind of fun to throw out there to the group, and I'm gonna keep going. So SP training observations. So what did I see while I watched this? Joe, I'm going to pause. We have someone trying to help us. It has to be set up as a webinar to get 500 people. That's what someone's saying, but we'll see what you discover. All right, back to our observations. So activity in an online format actually required 4 SPs rather than 7 over 2 days. So 7 were originally scheduled, but only 4 to do it online were required. So I'm going to come back around to that, but I was thinking about that right in a director role as cost. So I'm going to say more about that in a minute. The first hour of a 2-hour training session wound up being spent on technology and relation logistics, and this was our first time, so I know this is going to get more streamlined as we go along, but it was something to consider. So when I thought about the fact that 4 SPs were hired rather than 7, well, maybe in your initial implementation, it would probably be a good idea to allow for a longer training time. I think we could have really benefited from a 3-hour time that first time through. Something I really liked that Joe did in the training was he highlighted the difference between simply sort of regurgitating the details in the case versus impromptu delivery. Now, this is something that we as SP educators, we do this routinely for face-to-face cases, but I think in an online setting, it sort of has a little bit different implications. You see right here, we are focused on our faces, right? So much is about the face and the expression. It's about pacing. So all those things really, I think, are even heightened when you're focused on the face. We had faculty. We want to thank our faculty who zoomed into the trainings for the trainings we've done so far. And what we're thinking about is faculty zooming into these trainings routinely when we're hopefully back in our centers and up and running and doing face-to-face training. Why not offer the option for faculty to zoom in? Could be useful and convenient for them, could have implications for better faculty availability and attendance at our trainings. We also, this was kind of a fun moment in the training where we talked about how much of the body should each SP show, and I loved it. I remember Jeremy, one of our part-time trainers, got up and he was sort of like moving his computer around, and my impulse on that was, let's not move our computers around, like moving stuff and stuff getting unplugged. And if it were me, I would trip myself. That would be maybe a hazard. So we really realized there was no need to show anything but the face and upper body, and we could narrate our physical exam findings. So that's what we did. I observed that sharing documents on the screen like we're doing now, for me, it focused the SPs in a different way. So I started out as an SP trainer, and any of us who've done that over time, it's like, teaching any group, right? People are, hopefully mostly engaged, but there are times where, you'll see the occasional person check out a little bit, or they're texting or doing whatever. And so this meant I saw everybody's face the whole time. They were very zoned in and focused on what we were doing. So I thought that was interesting. And then finally, an idea for the future, and I alluded to this earlier, that this online SP training could be convenient. It could be cost and time saving measure for in-person formative events, particularly those where either it's completely history-based or interview-based, or where could be adapted to what we did, narrating those physical exam findings. Next slide. And so I also observed the SPs and their feedback at the end of the training. And so these are some of the things that they had to say, and one from each of them. So all four had something to say. The first one talked about the opportunities that this new online training format presented, which I thought was terrific, and how they thought, wow, this is probably reflective of what's happening in healthcare and what's needed in healthcare. And I thought that was so insightful from one of our SPs. Then another one mentioned the concern that online delivery of SP performance is authentic so that it's useful. She wanted to make sure her portrayal was authentic. And, we hear that in face-to-face settings, and we have evidence and support for that later in the presentation. We had another one talk about how narrating the physical exam findings is totally new. So they wanted to make sure it didn't sound rehearsed or sort of scripted, as opposed to handing a physical exam findings card. And I thought that was particularly interesting because I think, we all know it. You've got to suspend disbelief and break that fiction contract when you hand that card out anyway. So I thought that was, something kind of interesting. And then finally, our last one discussed that she wasn't as challenged by the portrayal aspect of this, but she really was concerned that she wanted to be able to offer meaningful verbal feedback. And I thought that was interesting as well, because that might come up in a face-to-face training. So that's what the SPs had to say. Next slide.
Thanks, Lou. I think it's important to re-emphasize the piece that you mentioned at the start, which is our staff had very limited experience with Zoom prior to a week before this project. And so we tackled this onboarding experience as a team because we knew we needed to figure it out together. Very early on in looking at Zoom, we had started to conceptualize using the breakout rooms as exam rooms, but we really didn't know how to do that. And so we tackled that by scheduling 2 60 to 90-minute Zoom meetings where 7 of our staff members simply practiced with the settings and flow, worked closer to moving people through the Zoom space like we would for the actual project. And so it was very much a collaborative discovery approach. Most of our energies were focused on understanding the nuances of breakout rooms and of the host controls, because that's where we felt like we had the most to learn about making the flow work as we intended. What we quickly conceptualized in terms of a framework that would give us some of the same features in this virtual space as we had relied on in our physical space was using the main session. Again, we're all in the main session right now in Zoom. That's where the learner pre-briefing would happen. And then we knew we needed to schedule 4 breakout rooms within the meeting, one for each of the SPs playing the abdominal pain case on that Friday. Another breakout room would be where we would move the learners to debriefing. And then Joe had a really great idea that we needed a space as a team to be able to talk openly, to troubleshoot on the spot, because this was our first time doing this. We weren't sure what we were going to need to solve. And so creating an additional breakout room for the M simulation staff, our team, to openly dialogue has served us really well. Additional things we discovered, we identified essential settings for learners to replicate essentially what would be a telehealth screen. Right now we're seeing a lot of screens, or we have the potential to see a lot of screens on Zoom. We felt like that could be a real distraction. And we wanted our staff to be able to be in these breakout rooms where the encounters were taking place without taking up real estate on the learner's screen or distracting their attention or making them feel extra observed. We also figured out a waiting room, which you all got to experience as part of this. That gives the host of Zoom some control over who enters that meeting space, or in our case, the orientation, and at what point. That's particularly important for rolling orientations, or when you have waves of people coming, or maybe you're addressing content for a certain audience that isn't relevant for the next audience coming through. We also have some specific limitations to what Zoom will do at our institution because of HIPAA requirements and how we're categorized as part of health sciences. So for example, we can't save directly to the cloud. So we spent some time in those early days looking at how are we going to do some workarounds to recording, how are we going to work within our context. So you may have some solves for some of how we've created strategies that because you don't have these sorts of limitations. So I just preview that for you. We came up with preliminary roles, and we really approached this from the standpoint of let's over-resource this from the beginning because this is new. We don't want to fail. We're a group that wants this to be perfect. We want this to be seamless. We want people to have a good experience. So let's make sure we feel supported by each other in doing the best we can for this. So the Zoom host is who we've been calling the driver. Joe is driving today. He's admitting people into the main session. In our simulations, the driver also moves individuals into and between breakout rooms. They're managing the timing. So we have a different strategy in our center for that, but the host will manage timing. They can create broadcast banner messages that get sent out and appear as text in the breakout rooms. That's a helpful strategy in timing. And they're also providing technical assistance and troubleshooting. So we put some of our most tech savvy people in this role to get started. We also had one individual facilitating the pre-briefing and debriefing, which freed up that individual to observe the encounters because we did a pre-briefing at the very beginning of the simulation and at the very end after all the cohorts had been through. We also felt like we wanted a staff member in each of the breakout rooms to help make audible those text banner messages so that individuals heard the timing announcements. And we wanted them to be there to provide technical troubleshooting. So we assigned them as a co-host role within Zoom, which allowed them enhanced functionality. And then as we always do with our simulations where we're using standardized patients, we have somebody in the role of SP lead who's facilitating the SP pre-briefing and debriefing, providing oversight for their performance, generally making sure if there's something happening with the SPs, we have a point person who can communicate and support them. So those were our preliminary roles. We thought about the 30 minutes prior to the start of the learner pre-briefing a little bit differently. We wanted to make sure everybody had established connectivity. So all of our staff on the project zoomed in 30 minutes before. That also gave us an opportunity to use a huddle, much like we do on site when we're all moving quickly between many activities and are managing a lot of details. It's especially important in a new situation with all these new features to review roles and flow, make sure everybody's clear on what we're doing. We had the SP zoom into that same session 15 minutes before the learners. That was our way to get them through in advance of the learners, make sure they had that connection. And we moved them almost directly into the breakout room where our SP lead could work on pre-briefing, tending to any questions, reviewing case details with them. And then we worked on admitting the learners into the waiting room 5 minutes prior to the orientation, just as we did today, so that they had an opportunity to start getting their technology configured for their needs. You got to experience a Zoom poll. It's the same Zoom poll we used with learners when they entered the pre-briefing space, the main meeting in Zoom. And that gave us a quick sense of where people were at with their perceived comfort. So we could customize the pre-briefing. We used narrated slides for PowerPoint. That gave the facilitator a chance to think about going a little more slowly over some of the technical information, or maybe going a little more quickly and waiting for questions to come via chat. We thought about many of our best practices in pre-briefing for simulation, but we wanted to make sure, particularly for this setting, that all staff members were visible in this pre-brief and that their video was on at the start so we could acknowledge them and introduce them. And it felt particularly important so that learners knew that we were here to support them and that they didn't feel like they were being watched or observed in a way that had some other quality to it, and that it really felt more supportive to them. Our second slide in the pre-briefing actually focused on technical settings. We wanted to make sure everybody got their technology squared away in the beginning. We recommended specific features for their setting to best replicate the telehealth pieces. So we had them choose speaker view. We asked them to disable the non-video participants. That allowed our staff in the breakout rooms to not appear on their screen. And then we gave them instructions when they got into the breakout room that they should pin the SP video. That makes the SP video appear across the full screen and gives the student a better view. We weren't sure what size devices people had, so we thought this was a particularly important piece. But just as we do on site, we applied best practices around goals, describing the assessment, the ground rules, the fiction contract, the logistics. The one piece we don't normally reveal during the pre-brief is the learner instructions. And we're still working out how to do that better in Zoom and would love to get feedback from all of you if you've got suggestions. We opted for revealing them on a slide in the final 2 minutes of the learner pre-brief. We ended up needing to truncate that a little bit for how much content we might normally put in learner instructions. Again, if somebody was using a smaller device, we were sensitive to how much text was on the screen. And we also made sure to narrate them. So if anybody was having any visual issue on reading the instructions, they were getting the verbal piece as well. And immediately after that 2 minutes, the first round of students was sent into the encounter. A few tips or strategies we've learned about the pre-brief. I'm experiencing this now as the person sharing the screen. It's difficult to have other Zoom windows open. They tend to cover some of the content on the slides, and it's hard to be focusing on your slide content and monitoring chat and taking attendance. It's really helpful, just as we've assigned roles among our team today, it's helpful to have other people support that. It's been very effective to have one person monitoring the chat, especially in some of our larger projects, and interrupting or interjecting those questions in a timely and appropriate manner so that the facilitator of the pre-brief can respond to those. Also, we'd suggest preparing for the possibilities of connectivity issues as a facilitator. Important to save any necessary files locally. That just takes one variable out of the mix. We all have these slides up on our computers right now. Should something happen with my connection, another team member is prepared to step in, has those files, and that's a strategy we use in the pre-brief as well. And you don't see it right now, but Joe, as our host, is doing what he's done in our simulations as well. He's continuing to monitor the waiting room for late arrivals or anyone who needs to re-enter. That's particularly important in the simulations. If somebody loses their connection, they're going to need to rejoin the meeting. So somebody's got to be on the lookout for that. And that level of coordination is best handled by somebody who can be tuned into the technology features. I'm going to turn it to Joe to talk more about our encounters.
Thank you, Anne. We have some great comments actually going on in the chat, so we'll get to those at the very end. So a lot of good ideas are coming up as we're going through this presentation, so that's really, really helpful. So at this point, we were ready for the encounters to begin. One of the things that I wanted to let everyone know is that before orientation was complete, the driver really does need to make sure that all necessary staff and team members and faculty have the particular privileges within Zoom so that they need before we actually do this. So you want to make sure that you create co-hosts. For this meeting, Anne and Lou are also co-hosts. So again, it solves a little bit of that connectivity issue so that if for some reason someone drops out, the entire OSCE, the entire event, or the entire meeting is not compromised. The other thing around the, I'm gonna let another person in. The other thing to think about with the breakout rooms, if you make someone a co-host, it allows them to move independently between the breakout rooms. You'll need to assign them first to their very first location, but then from there, faculty can jump between the 4 different exam rooms, go into the debrief room, come back to the orientation, and go back and forth kind of unobtrusively to the learner, but also independently for themselves so they can do what they need to do to really observe the experience and really get as much as they need to for that debrief. Once we're ready to do that, the driver opens the breakout rooms. all Zoom participants must be assigned to a breakout room or moved. With the learners, we chose to not pre-build. One of the features of Zoom is you can pre-build a schedule based on where the participants need to go. We chose to move the participants as opposed to build them, but we also made sure all faculty and our staff had the co-hosting privileges so they could move independently throughout the project. As we were ready to go, I let the learners know that we had, or we were ready to move them to their exam rooms, excuse me, at the completion of orientation, so we did that. And you can go to the next slide, please. Once we had them all in their rooms, we broadcast a message across the screens. One of the things that we noticed about the broadcasting messages was that the message is rather small on the screen and it disappears fairly quickly. So as Anne mentioned before, we chose to have a staff member assigned in the breakout room to also manage those cues. If the learner missed that come across their screen because they were making a note or there was something that happened, one of our team members would unmute their audio and simply say there's 2 minutes remaining, just to make sure that the learners were cued into every aspect of the simulation. You can see here that we did a beginning, 2 minutes remain to begin the patient feedback and the end of the encounter. In our SP training session, we also cued the standardized patients to be essentially another mechanism that's in place to help safeguard against the learner going over time. And so if needed, when it got to that feedback portion with the patient could have stopped and said, I think they called time, we're gonna go ahead and start feedback. So a couple of different things there with the broadcast messaging as well as the verbal announcements. Once they were done with their encounters, we went and go ahead and moved them into the debrief room. We had 3 more rounds, excuse me, to get through before we did a final group debriefing of all 15 learners. So the learners were instructed to wait in the debrief room and they could work on other things until we were ready to start that process at the very end. One thing to note is that the breakout rooms, and maybe we'll go back 1 second, the breakout rooms can be a lot to manage. And one of the things that we figured out was that depending on the amount of learners per group or depending on the project, you'll want to be specific around how many breakout rooms you actually schedule or craft based on the planning meeting with your client. And next slide, we're going to go ahead and show you a quick video of about 3 minutes of the experience with a learner that has agreed to let us show this. This is going to focus primarily on the physical exam portion, which is that narration that we talked about. And really why we thought this was helpful is that you get to see the standardized patient and the learner have a little bit of a negotiation, if you will, of how to make this work. And you can see, even though it's not verbally said between the two of them, you can see the give and take between them and how they manage this interaction. So I'm going to go ahead and remove.
Joe, I think you'll need to take the screen share.
Right now.
I'd say it usually feels better when I lie down, so I probably wouldn't notice it when I wake up, but I don't know.
Okay, perfect. I'm going to move into my exam. So for the exam, I'm first just gonna listen to I'm gonna feel your neck, and I'm just gonna feel for any swollen lymph nodes.
There are no palpable or tender lymph nodes.
Perfect. I might check and see the size of your thyroid. Do a thyroid exam.
The thyroid is smooth without palpable nodules and non-tender.
Perfect. I'm going to listen to your lungs, or you know what? First, I'm going to look into your mouth. Yes, I'm gonna. Just to see.
Nothing. Everything's normal.
Everything's normal. Okay, no lesions. Okay. And then I'm going to listen to your lungs. I'll have you take a nice deep breath as I listen throughout your lungs, just making sure there's no wheezing or lung sounds that are abnormal.
Lung sounds are clear to auscultation with air entry throughout.
I'm going to listen to your heart, listening for S1 and S2, making sure there's no additional heartbeats, rubs, murmurs.
Heart sounds, rhythm, and rate are regular. S1, S2, no murmur, rub, or gallop.
Okay, I'm going to move down into your an abdominal exam for you. I'm going to palpate each of the quadrants. I'm feeling for any tenderness, any masses. I'm going to also check for your liver border and see if there's any enlarged organs as well.
Okay. Abdomen is slightly rounded. Abdomen is soft. There is mild tenderness to palpitation in the lower quadrants. There is no severe pain, guarding, rigidity, or rebound tenderness to any abdominal exam maneuvers. There are no masses or organomegaly.
I'm so sorry. Do you think we can repeat some of that for your abdominal exam? I got the, it's round and soft but tender in the lower quadrants. No organomegaly, no rebound tenderness.
Mild tenderness to palpitation in the lower quadrants.
Okay.
There's no severe pain, guarding, rigidity, or rebound tenderness to any abdominal exam maneuvers.
Okay, thank you. Perfect. You know, a couple questions I might want to go back to. I'm going to continue with your exam, but as a woman, I'd like to know when your last menstrual period was.
It started a couple days ago.
It started a few days ago? Okay. So you're currently on your men's cycle? Okay.
Okay, so we're going to go ahead and stop there.
So we're gonna go ahead and stop there. So you were able to see a little bit of the negotiation happening between the learner and the standardized patient, and really working through the trial or the first time with this narrated physical exam and this cueing sheet that the standardized patient used to help the learner get information they would normally get or elicit from their physical exam. Next slide, Anne.
So as we moved into learner debriefing, we had planned and did use the same debriefing strategy that we often use for larger group debriefings, which is based on modified plus delta strategy. And I was concerned, I haven't facilitated a lot of debriefings in a large online group, and I wasn't sure how students were going to manage kind of talking over each other. And it's nice to have an organic conversation with the students. And so I previewed for that. I said, we're going to try to create an open dialogue here. If needed, I will step in if there's confusion over who can talk, but let's just see if we can co-facilitate this as a full group. And by and large, everybody was very successful doing that. As you can see, we covered a lot of the same types of content that we would have covered if this were a face-to-face interaction. There was an additional emphasis on the telehealth piece of how to navigate the online experience, but a lot of positive takeaways, good contributions across the group. The first adjective that a student shared about their overall simulation experience was smooth, which was really interesting. I was expecting to hear awkward or some other descriptor, and really what that told us was, despite that there might have been a few glitches behind the scenes that we were managing that we knew about, for the students this really worked, and that was really exciting. I also want to point out that this is data that was captured in the whiteboard feature in Zoom, and so I was facilitating debriefing and Joe was managing the whiteboard, and that allowed me to put the gallery view up so that I could see all of the 15 participants and their faculty members and could better have that exchange back and forth and still capture this content. So it's available for the students to see and for us to have after the fact. We also routinely ask our students and learners to evaluate their simulation experiences. We have some specific telehealth items, but these are items that we actually assess across all simulation projects. I think it was really encouraging to see how much agreement and how much strong agreement there is across these really important simulation categories, that it was realistic enough, that it felt applicable to clinical practice, that they could work outside their comfort zone, that the debriefing, even though we were in this gallery format in Zoom, they were able to learn from the experience, and that they feel more prepared to manage these kinds of clinical situations in the future. And this global item, this was a useful experience. 85.7% strongly agreed that this was useful, which that erased any doubts we had about our ability to keep working to make this better, and that it is useful even if it's not perfect. We also asked for some comments from students, and these are verbatim off of their evaluation. We asked them to rate the 3 best things. Students said, still able to have the SP even though at home, seamless flow of experience, being able to do it without having to come to campus. I think that speaks to the future. Getting to experience the role of the provider in a telemedicine environment. Really important. We didn't see that as an initial goal. The feeling of being back in clinical. And that certainly speaks to where students are at with their lack of access to clinicals and how we can play an important role in that. And reaffirming my thought process with others through the debriefing. So debriefing can still be really effective and important for students in this setting. We also ask students what to change. We want to know how we can continue to make our simulation experiences better. And this is some of what they had to say. I think there should have been a 5-minute prep time before the first group had to go. As I mentioned, that first group, after that 2 minutes of learner instructions, got whisked into the encounter. They didn't have that walking time to get to exam room 4 or 6. They had to go right in. So that's something to think about. Patient information should be shared at the beginning of the breakout room. We're still working on that, and I think the chat will hopefully give us some good ideas and perhaps conversation after this as well. Longer virtual visit times for our first time with telehealth. We didn't think about that feature, but as we're continuing to work with faculty and adapting additional programming, that's something we're starting to discuss. Do we have an opportunity to increase time because this format is new and because this format might take a little bit longer where you can't talk over each other quite as easily or effectively? More clarity about physical exam instruction. So physical exam worked. They were able to have really positive evaluations and learn from the experience. But just as you saw, there's some things we can do for training, for case development and instructions that can help that process as well. Debrief with the cohort instead of waiting until the very end. So we waited for all 4 cohorts. That was very much a staffing choice. We had all of our staff deployed, or many of our staff deployed, supporting the rooms. But that's certainly something to be considering, is what are students doing in their downtime. And my favorite opportunity to change is more frequent opportunity to do this, which is a great thing to change.
And so we also focused on the debriefing of the standardized patients. Our simulation team employed and is using the emerging standards of best practice. We have a high emotion and a low emotion debrief checkout form. I'm gonna go back 1 second. We will sometimes choose to do that verbally and written. Most of the time, or almost every project, it's at least a written capacity. So in that debriefing process, I encourage the patients to think about this experience particularly. How was it similar? How was it different from the other work that they've done with us? And really give us insights and feedback on what went well and what things they were really challenged by. Just so you're aware that with the 4 standardized patients, they had been with us from a range of about 1 year to 5 years. So a range there in terms of their experience. These were direct quotes from the patients. I was concerned about this not being good enough and me not being good enough in terms of portrayal without being in front of the students in the IERC. Another SP had said, it felt so easy being in my home, made me feel more comfortable, almost to a point where I had to remind myself I didn't have abdominal pain and this was a sim. So some really good feedback from the patients in terms of how they felt about this experience, especially for some of them that have done several or numerous projects with us.
So again, some observations from the fly on the wall. What I saw was that it's critical to acknowledge to everyone in the planning and implementation stages, this is different from face-to-face, and that's okay. And I really want to reach out for a second to all of you in particularly leadership roles. The most important thing you can do for your team is to say, it is okay not to be perfect. This is new. Give people the freedom, the license, the creativity that this community has to work together and to make it happen. And as we're doing, you refine as you go. But it's so important because all of us take this very seriously to give that permission, to say it out loud, to say, it's okay, just do it. Let's try it. We can do it. what I saw was that learners connected with SPs to build relationships, to show empathy. It was exciting to see that happen in real time. I saw that the altering of facial expressions was noticeable and powerful. And this was really interesting because since there's such a focus on the face, when it comes to showing compassion or empathy, you could really see that. And that was exciting. We opted to make space to acknowledge COVID-19, or in other words, the world around us. We saw that as useful, and it helped create authenticity in encounters. And I found this fascinating because so often we have our script, we have what everyone's going to say, but I think this can encourage us to look at future case scenario development and say, let's be open, let's bring the world into our cases, and that creates authenticity, that creates realism, rather than sort of suspending disbelief at the expense of authenticity. And then finally, our team members, the simulation staff members, felt the event was choppy. I was sort of watching them sort of get, critical of themselves. And I was sitting there going, yes, it happened, So I think Anne's mention of the learner's first response, that it was smooth, I'm going to tell you, she didn't believe it. It was actually great. I watched her ask once, twice again, but really, is there anything else? And I was thinking, they thought it was smooth, So I think this was all very telling. Next slide, please.
So this is just a slide to help you visualize what we did. About 4 days later, we scaled up this project, going from 15 DNP nursing students up to 104 veterinary medicine students from Friday to Monday. You can see here, it's a little bit hard to read, but I'll just give you the basics, that we decided to go from 4 to 6 breakout rooms. And you can see that we have 4 learners per breakout room. They were put into pairs, our 2 active participants and 2 observing participants. The observers had a role or a guide that they were filling out while they watched the encounter. This one also took a next step for us in that we moved the learners between 2 different cases, a large animal and a small animal case. So that was something that added another layer of complexity in. And then they were also moved from there into the debrief, and we had rolling debriefs for this one, excuse me. So you can see here there were a couple of, we kind of decided to take those next steps in certain key areas. Now, as the person who hosted or drove for this simulation, I can tell you that trying to move 24 or 48 participants at one time to different breakout rooms can be particularly challenging. You're able to do it, and we were able to do it. I would really encourage you to be mindful about that and think about the time that you allow between encounters, because we were able to make that happen. It just had to buffer a little bit of the time there. So that was a big consideration. We also were fortunate in that with us having created an SP lounge or a staff or a faculty breakout room in the very first simulation, when we got to this one, we needed that extra room to actually move participants. So I moved the participants from 6 into this empty room, and then you can move 5 to 6 and down and so on, so that you weren't moving learners into a room where other participants were already in there as we moved through this process. So as you're thinking about multiple encounters for learners or multiple stations that they'll go through, definitely consider additional rooms so that you have that moving factor. And then I think one thing that we were mainly just making you aware of is that when you're thinking about scaling up or scaling down the projects, really try to situate yourself within running the actual project to see exactly how many participants are manageable and how that impacts your orientation and your debriefing as well. Next slide. So a few lessons learned here, I'm gonna let another person in, was that we figured out that it would be really helpful to use Zoom screenshots for orientation. Especially with the standardized patients, there were tech issues in terms of working through the different devices. And we didn't know that going in, that it's different on an iPad versus on an iPhone versus on a desktop computer or a laptop. So really taking screenshots of all those different platforms so that you can have those at you're ready to share with the patients or the learners or with faculty to really help navigate that. We thought it was really important to pair a tech person with an education person. Anne mentioned some of this in some of our staffing before, but we really made it a point so that to think about people not having too many things to do or extending themselves too far. So we had someone helping with the debriefing whiteboard, we had someone driving, we had lots of different people behind the scenes navigating different aspects of this. We also, There we are. We also realized that supporting faculty also needed to be thought about ahead of time, and really the orientation to Zoom and creating guides and how-tos of making sure that faculty feel supported and that they're able to move through the simulation so that they can focus on the education. We did rolling orientations, as I said, for the veterinary medicine project. For larger projects, it takes some more support, so really be mindful of that. And this seemed like a small thing, but a timer app became really, really critical when you're trying to manage all these different aspects of these announcements that are being broadcasted to everyone without actually being able to verbally announce them to all rooms. And then we also made sure that if the students finish early at a station, we had the standardized patient mute their microphone and their camera, so there wasn't this awkward silence where they were staring at each other until our team could get around to those rooms and actually in Zoom move them to the debrief. And then we're still thinking about better options for delivery of learner instructions. As Anne mentioned, we put those as one of the final slides in the orientation. We have thought about potentially putting those in the chat in each of the breakout rooms that the learner could click on them at that point, which might be really beneficial when thinking about patient charts or any sort of other images or files that you want the learner to be exposed to. There are lots of different ways to accomplish this, and we're still thinking about ways that that would be successful. Next slide.
So I just want to acknowledge we have about 5 minutes left officially together. We're going to go through the rest of what we have. We should be able to cover it in that time. Obviously, we had a lot to share with you today. We've had some incredible questions in the chat. I want to encourage you to keep putting your questions in the chat because we will get back to you. We plan to download the chat. We will answer the questions and we'll make it available in a script format for you along with the recording of this session. So we're going to go ahead and do that, but a reminder to go ahead, keep those questions coming. And also, if you haven't already, please put your full name, your institutional affiliation, and don't forget to put your email into the chat so we can get back to you. I will answer that we've had a lot of questions. How many staff did it take for us to do this? I will be very transparent. It took seven full-time people working together to mount this first exploration, this first nursing event. But it's a great transition into sustainability. We can't keep doing that. 10 days into this poor team looks like, are you kidding? We can't keep doing this, and they're right. So we have support from leadership to explore, how can we make this more sustainable? So here's some do's and don'ts. Do be mindful of the health and wellness of the simulation team members. It's critical. That's number one. Do not overschedule events using multiple events on the same day. We're likely going to have to scale back, you know, and that can be a question of priorities. But there are creative ways to do that. You might be able to combine events. Our AVP Carolyn Porta and the Simulation Oversight Committee had this great suggestion of what if we find events from different learner groups and encourage them to work together and create one event with similar task goals, learning objectives. What a great opportunity for interprofessional education, which in quick preview, that is likely to be one of our upcoming sessions for this series online. Reach out to SB Education colleagues if you have a small staff. I was thinking, if you've got a small team, what about reaching out to others in our field and combining efforts? What a cool thing. You've got multi-institutional collaboration right there. Do create multiple teams if you're fortunate to have a large staff, and we're working on that now for sustainability. And you can see here today, there are 3 of us. I think that's a pretty good model to go with. This gives you the opportunity to use, if you have on-call or part-time trainers, to keep them working, keep them employed. Student workers, you know, we all have those folks in our world, and we want to help keep them working too. Do take time to thoroughly debrief, as we've done here and shared with you. Do reach out and share the significance of everything we've covered with your faculty and institutional leaders. Ask for support and collaboration. We are so fortunate here at Minnesota to have that. And I think a lot of times sim educators, we're doing things behind the scenes, we're making it happen, and we don't share what we're sharing right now, which is all the work that it takes to make it happen. They need to know this so they can better help you, and they can help you think through these challenges. Please don't be hard on yourself in the early days of adaptation. Cut yourself a break and congratulate yourself when you implement your first event. You will. Next slide, please. So to wrap this up, SP events in full online Zoom format. They are doable. They are effective for healthcare learners. And producing these events allows us to support our healthcare workforce in educating the next generation. Now more than ever in this time of COVID-19, that's important. And we need to embrace opportunities for multi-institutional collaboration and IPE. And I think even most importantly, imagine the future of healthcare simulation education. Look what we can do in creative spaces. And this is important because a lot of our disciplines that work with us, some of these disciplines, they can have up to 50% of their requirements for clinical time, for clinical education, be through simulation. So online platforms will help us meet that need, and it will be good for everyone, really, eventually, when we get past this. We're doing it out of necessity, but let's look to the future of how this can help us as we get past this time. And I think I want to circle back around to feedback from one of our learners who said, being able to do it without having to come to campus. And I think that just speaks to our future beyond COVID-19. And the title of this series ends with the word beyond. We will get beyond this. And I'm so happy to have you all with us today. We want to support you in that, and we are with you. Please reach out to us with questions. We are going to download the chat. We are going to answer those questions and make it available along with our recording. And we can't thank you enough for being with us today. So we are going to end this today only because we are at time, but look out for future resources from us. And again, thank you. Best wishes to all of you, and special thanks to our healthcare workers who are putting themselves on the line for us. Thank you all so much.
And like Lou said, as you're exiting, go ahead and please put those questions into the chat. We will make sure to answer all of them and make that available to you.